Brilliant. Thank you very much. So I'm going to talk a little bit about me, but about the 100,000 Genomes Project and the new Genomic Medicine Service that's being developed that has come partly out of the work of the 100,000 Genomes Project. I think Nick has sort of very clearly framed some of the stuff for me that I'm going to be talking about, which is quite lucky, which is about the infrastructure and the challenges being built. So I think it's going to be quite a different talk from what other people had, because I'm coming very much from a perspective of what we're developing within the healthcare and with NHS. I should probably put my hand up and say I'm a public health consultant by background, and also within Genomics England there were staff awards that we have each year, and I have won the one on being most optimistic, which is why when Nick says people know about transformational change being painful, I do really know it's really, really painful, but when I talk about this, it may sound slightly easy, and it's definitely not. I've learned, because people have pulled me up on that before, to make it absolutely clear just how challenging bringing change across the whole NHS actually is. So, as I said, first I'm going to talk about the sort of the 100,000 genomes, and I think that there are some interesting things with regard to personalised medicine within that, but then into sort of where it's going with the Genomic Medicine Service. As it happens, you mentioned the Olympics. The 100,000 Genomes Project was actually a legacy of the Olympics, because it came out of there was various horizon scanning pieces of work that were done to say what should the UK be investing in over the next 5 years, and one of the ideas that came out of that was the 100,000 Genomes Project. So and then it was announced, and we actually sort of reached the goal of sequencing 100,000 genomes in December of last year, although we've not returned results to everybody. So as far as I'm concerned, the job is not really done until we've done that. And it really has been a coordinated response across the whole of the healthcare system. It has required collaboration with different sets of people. And one of the key things is that it was set up, well, I should probably say actually what it was set up to do. It was set up to do 100,000 genomes through the NHS in people with both rare diseases and cancer, as a sort of a broad summary of the basic thing that it was trying to do. And that actually was implemented by genomic medicine centres that were commissioned by the NHS that consisted of, well, they were virtual organisations and in effect covered 85 hospital trusts across the whole of England. So it was actually, the intention was that it would always have that national coverage to provide equity of access to the programme. Also, something that I also like to say is that it had a particular strand on health and education and the need to upskill the workforce to do that, because when you're bringing transformational change, actually driving the knowledge base is also really key and important. So I thought for this talk it would actually be potentially a little bit interesting to just sort of talk about how, using the rare disease bit, practically our analysis is working to give people an idea of that, because I think that that's quite important. So the sort of the patient and the family were recruited to the 100,000 Genomes Project. They were given, their clinicians gave phenotypic data and pedigree data, and that was put into a central system, and their blood was taken and DNA extracted, and it was sequenced. And all of that data was put into the Genomics England sort of data infrastructure, which is here, and that was put through our bioinformatics pipeline. And the bioinformatics pipeline was looking for sort of known findings. So where our current knowledge base was, it was trying to identify diagnoses. People who were recruited to rare diseases had to be recruited, had to have all the local testing that was expected in terms of their healthcare before they were recruited. So in essence, they were enriched as being people who would be unlikely to find a diagnosis from new knowledge. And yet actually from this process we're still getting a sort of a 20 to 25% diagnosis rate, and in some areas like eye disease it's sort of up to 45%. So that's really exciting for the patients. But the really key bit that I wanted to draw your attention to is the bit over here in the corner. Because we've talked about the need for big data, and we've talked about the importance of big data in healthcare and precision medicine. The challenge for us is, how do you actually make the most of that big data? And so the people who took part in the 100,000 They also agreed to all of their data being put into a big research infrastructure, which people could come into and access, but they could only remove the data in aggregate form, but they could do their analysis within that. And the GSIPs are the Genomics England Clinical Interpretation Partnerships. And these are the academic researchers who are then doing analysis on this data. But it's not just, cancer whole genome analysis reports. We also did cancer. Again, this data is being provided for research, but also in terms of the reports that are going back to people. This included identification about whether or not they would be eligible for trials or other such sort of information. Being absolutely honest, at the start of the program, when we were trying to get it operationally worked, the timelines for returning the results meant that the actionable aspects of these reports were probably past the point where they were relevant to people. In fact, we've had a number of cases where people have had recurrence, and this has actually only been useful, or has been useful at the point of recurrence, to identify things that might be relevant to them in terms of trials and other things. But actually, by the end of the programme, we had a sort of a fast-track, clinically urgent pipeline that was getting results back to people for the Genomics England part of the pipeline within 20 working days, usually shorter than that. When you consider how long it took to do the first human genome, that's really quite incredible. So this means that there's a whole opportunity and infrastructure that becomes possible for doing more molecular-driven diagnosis and engagement in research opportunities. I truly believe that actually part of healthcare is now having the opportunity to be involved in research. And that's something that should be open to everybody, not just the people sort of in Oxford and Cambridge, but the people in Hull. And there's quite good evidence that involvement in research leads to better outcomes, full stop. And therefore systems that allow us to do this is really important. And part of the shift that I think genomics needs to bring is towards driving that idea, as this is a part of standard clinical practice. I should perhaps also say, given the conversations that happened earlier, I totally get that genomics isn't personalised medicine, it's only a part of it. What I find interesting about genomics is that I think that it's often driving some of the conversations that relate to the other stuff, because in terms of practical implementation, it's much further ahead. And that's why I find it quite exciting, even though I must admit I'm not really a proper genomics person. But don't tell Genomics England that, because I will be in a lot of trouble if they ever found out. So where are we in terms of progress to date? Well, actually, I think when you bring about sort of transformational change in the NHS, one of the things that is important is that to drive that change, the frontline healthcare workers have to understand that this is important for patients. And there were a number of challenges in getting the 100,000 started. We were aiming for 100,000. Towards the end of the programme, I think the idea that this was leading to real patient benefits got embedded, and so instead of collecting 100,000 samples, the NHS slightly slipped up and recruited 122,000 samples, which we're now still sequencing. That's incredible. There were about 30,000 of those that were cancer samples, that were fresh frozen samples. This was engineering new pathways within the NHS to deliver these sorts of samples. And this was happening in district general hospitals as well as teaching hospitals. I think there were over 400 fresh frozen pathways that were set up. And actually the change that you saw within pathology as people went from this just can't happen to we know that this should happen but we can't do it, to now actually we're beginning to see how this can work. And that was really great to be a part of. As I said, the really important thing is the results that are getting back, and we're starting to return those. We return on average reports or sets of results that are then analysed by the NHS of a rate now at about 500 a week, whole genome analysis. But I wanted to touch on really the clinical and the research aspect, because as I said, in terms of thinking about where the future is, how we bring the two of these together, the research and the clinical, it is really going to be absolutely key. And I think not just to genomics, but the whole of personalised medicine. So the Genomics England Clinical Interpretation Partnership is basically people join it, and in return for agreeing to work on the data, they get free access to the data. And so far in the research database, there are over 90,000 genomes. I think we include hospital episode statistics as well as clinical data, as well as ONS data, as well as other things. And at our last data release, there were 1.6 billion individual clinical data items, if you interpret that broadly to include sort of hospital episode statistics, in our data centre. That is an awful lot of data in one place for people to work to. But it's not just academics who have access to this de-identified data. It's also industry as well. So we have agreements with industry, and we have the Discovery Forum, and they are sort of starting to work and access this. And I think, to be honest, we hoped that there would be full access to this data sort of 2-3 years ago. Really, people have only getting access in the last year or 6 months in terms of the full sets of data and people being fully onboarded. But what we're already beginning to see is that actually diagnoses, or rather clinically relevant information that should be fed back to the NHS, is being identified by researchers who are working on this database. So this is a kind of a new model whereby actually research activity is leading to clinical insights, and this is a mechanism for formally and actively feeding it back, which is really quite exciting. I wanted to give one specific example, and the interesting thing here is, this, or maybe it shouldn't be interesting, but to me it is that this is actually one of our commercial partners who was doing research. In terms of the sort of technical aspect of this, our pipeline at the time when people were put through were not actually looking for CNVs. That was something that we had to develop. We've now developed it, but this company was looking in the research centre to identify and do research, and identified several people whom would actually have a potential diagnosis, and so that has been passed to us. And we're working with the NHS to work out what the best way is to feed back this information, because it can't be just fed back in a sort of uninterrupted, unconscious stream. It has to be, it has to happen in a way that doesn't overwhelm the NHS. But to sort of see that actually the research environment is actually leading to things that are being passed back directly is really exciting. And I think that there's a wider message for how we deal with big data and precision medicine, and how research interacts with regard to that. It's really interesting because we went out, because what makes this possible is the sharing of all of the data and it being present. And we've got a national participant panel, and they are involved in a number of aspects. They're involved in our access review committee, so they are actively involved in determining who gets access to the data, they are very much for this sharing of data. They see the importance of it for them in terms of the potential for new diagnoses. In fact, there was one application that we had which wanted to do some geospatial analysis, and we were very worried about this because we promised them that we would protect their identity, and that's part of all of what we sort of feed back. And they kind of went, well, that's good and that's important to us because we want it to be used safely, but it's not good enough that you can't allow good research, so go away and figure out how this to be done. And I love the fact that they are the ones pushing us forward on the sharing of the data. And I think that it's probably, I recognise, but this is important, it's because many of these are affected and lead to potential benefits for themselves and their families in doing it. But also they're incredibly altruistic because they want those benefits for other people as well. But we've actually sort of just engaged in a public dialogue, and a report is going to come out of this. And actually the public in general is pretty much in favour, at least, of people being given the choice about whether or not their data should be shared. So I think that the sort of 100,000 has really demonstrated the importance of bringing the data in a practical sense together for different aspects of working on. And actually the ecosystems that we think about in terms of how we lead to driving this forward is also, essentially it's a big experiment, but it does seem to be working, and I think that's insights for the future. Where are we going now? Well, the future is the NHS Genomic Medicine Service, and this is being commissioned and delivered by NHS England, not Genomics England, but Genomics England is delivering and supporting aspects of it. There are some key points about it. So it's got a national test directory, so this will state for which indications people should have which test types, and that includes for certain rare diseases, there are 21 indications, including sort of intellectual disability, which says whole genome sequencing should be the test of choice. And also for cancer, it's got a sort of a standardized set of testing for that. And for 3 cancer types, sarcoma, pediatrics, and hem-onc, it is suggested that whole genome sequencing should be the test of choice for that to inform treatment. It's working towards operating to common national standards. There's some really interesting stuff about data and data sharing. So at the moment, what we're pursuing with them is a concept that actually they're moving to sort of 7 genomic lab hubs across the country, but that these are all part of one virtual lab, and therefore as such, everybody and all of the data within that lab and that system, it's appropriate for people to have access within that system to that data, which really makes sense, particularly in a rare disease context, because if you've got someone in Newcastle who is the expert, then you want them to have access to the data and work and interact with people in a different place. And to date, there have been challenges about data governance. The other thing that is really important is, as was said earlier, the genome is basically uninterpretable unless you've got other genomes to compare it against. And therefore people have to share their data to take part in having the clinical service. And I think that is really, that's their choice about whether or not they do that, but they do have to have, choose they have to choose whether or not they want that in terms of the test. They have a choice about whether or not they want that data to be made available in a de-identified way for researchers. And so I think that that's really important, because actually we can't offer these tests without the data being brought together. The system that we're building, which is a national system, is real. It's out for beta testing with the Genomic Lab Hubs. I've shown a picture of it because, as was discussed, building informatics systems in the NHS is challenging. Look, it's real, it's being tested. We've also got the challenge in terms of the future of the announcement. So just when we did 100,000, they came along and said, we've got to do 5 million. It's kind of an interesting thing for us to be working with now. I should be really specific about this, and I've got the numbers broken down. So that's a definite commitment to 1 million, 500,000 for UK Biobank, 500,000 for NHS clinical services, and everything else is an ambition that we have been tasked to try and achieve. So that's the bit that we have to sort of work on. But I think that the structure is there. I've realised I've talked too much, but in terms of, very quickly, I see this as an infrastructure that allows the implementation of personalised medicine. I think that building the infrastructure will allow the research to be done that will then be able to be translated into healthcare. And for me, that's the really important bit about where the genomics is going, is that it's developing that. And just quickly skipping through some slides, because that was basically all I was going to say. My final comment is my comms team do all of the slides for me, and they're desperate for followers, and apparently I'm their best recruiter. So I do have a heartfelt plea to all of you to sign up and follow us, because it really helps me out.